Okay, so my brief is to talk about how surgical interventions affect gait and Perthes disease. And this is a brief overview of my talk. So to start with, we all know that Perthes disease is an idiopathic avascular necrosis of capital femoral epiphysis. Typically affects children between the age groups of 4 and 12 years. And the disease passes through the stage of avascular necrosis, followed by fragmentation, followed by reossification, and finally the healed stage. Though all cases of Perthes disease heal, the problem over here is that in the early stages, the femoral head, it loses its mechanical integrity, during which it is vulnerable to deformation collapse, which leads to extrusion. And if the hip is allowed to heal in this extruded state, it will be aspherical at healing. The aim of treatment in early stages is to achieve a head as spherical as possible, because we know that sphericity corresponds to good long-term outcomes. This can be achieved by containment surgery. Now the rationale for containment surgery, whether it be femoral containment or acetabular containment, is that in the initial vulnerable stages, it contains the head within the acetabulum, which then acts like a spherical mold, and due to the property of biological plasticity, by the time the femoral head heals, it assumes a spherical shape. Whether to perform containment or not, that depends on multiple factors, namely the age of onset of disease, stage of disease, severity of disease, whether the femoral head is extruded, and what is the range of motion of the hip joint. So before we go ahead as to how containment surgery affects gait in Perthes disease, let us first understand what are the gait disturbances in Perthes disease. So in the early stages, these children can have recurrent episodes of synovitis and hip irritability, because of which they can have antalgic gait. But these episodes are typically self-limiting and they get relieved with NSAIDs and rest. However, as the stage of disease advances, the cause of gait disturbances become more mechanical. So you get extrusion and therefore impingement, which is more anterolateral, because of which there is a restriction of hip range of movement, mainly abduction and internal rotation, and this can lead to alteration of hip kinematics. Also, you have AVN of the proximal femur growth plate, due to which the growth plate closes prematurely. This in turn leads to coxa vara, that is a short femoral neck. Also, there is a relative proximal overgrowth of the greater trochanter. This leads to hip abductor lever arm dysfunction, which leads to Trendelenburg gait. Additionally, there is leg length discrepancy in around 10 to 15% cases. So the average leg length discrepancy is about 1 to 5 centimeters, and it is likely to be more in severe disease, that is Herring's group C. There are some gait analysis studies which show that there is an increased anterior pelvic tilt, decreased hip extension, and decreased hip flexor power generation in children with Perthes disease. So now that we have understood what are the gait disturbances in Perthes disease, does surgical intervention affect gait in Perthes disease? Now the literature on this is a bit limited, because most of the studies on Perthes disease, they mainly focus on femoral head shape as an outcome measure. The effect of gait is not really well studied. So what we will do here is we will study the effect of surgical containment on coxa vara, proximal trochanter overgrowth, and limb length discrepancy, because we know that these are the factors which ultimately affect gait in Perthes disease. And when we talk about containment, we'll mainly talk about femur varus osteotomy, because this is the standard osteotomy which is performed, especially in India. So this osteotomy is basically a simple subtrochanteric osteotomy, an open wedge osteotomy. And in addition to this, a greater trochanter apophysiodesis is performed to prevent proximal overgrowth of the greater trochanter. This technique has been described by Benjamin Joseph et al. So how does femur varus osteotomy affect the neck shaft angle? Does it add coxa vara to Perthes disease in which there is already some pre-existing varus? So in the immediate post-op period, definitely with a femur varus osteotomy, the neck shaft angle decreases, obviously, because you have given a varus. However, it is important to note that the varus at the surgical site gradually remodels over a period of time, and complete remodeling is usually seen by skeletal maturity. Here is a case example of the same. However, there is a caveat to that, that is your target neck shaft angle should not be less than 115 degrees. More severe varus may not remodel. So care should be taken during surgery that the angle, neck shaft angle should not be less than 115 degrees. Moreover, there are studies which have shown that more varus is not needed for containment. What is the effect of femur varus osteotomy on proximal trochanter overgrowth? Does the GT apophysiodesis improve that? And there are studies which have shown that optimal correction of proximal trochanter overgrowth is seen in most patients, which in turn improves Trendelenburg gait. This effect is best seen in children who undergo surgery below the age of 8.5 years. What is the effect of femur varus osteotomy on limb-length discrepancy? So every 10 degrees of closing wedge osteotomy causes a limb-length discrepancy of 4 millimeter. However, we usually perform the open wedge osteotomy, which has negligible effects on limb-length discrepancy. What are the laboratory gait studies? What do they say about the effect of femur varus osteotomy? So post-operatively, there is improvement in kinematics as well as kinetics of the hip joint, as noted by this lab gait study. Is there a role for gait training? So this is an interesting study which has shown that some children who develop good hip abductor strength and who develop a method of walking in which they sway their trunk towards the affected side, they have better joint reaction forces across the hip joint, and therefore this study suggests that there may be a role for gait training of children with Perthes disease so that they develop an unloading gait pattern. This is another study which confirms the same, that gait training might help in Perthes disease. So to conclude, femoral varus osteotomy does add coxa vara in a case of Perthes disease. However, this varus remodels. GT overgrowth is corrected, especially seen in children less than 8.5 years age. Limb-length discrepancy caused by femoral varus osteotomy is not clinically significant if you are performing an open wedge osteotomy. Femoral varus osteotomy does improve hip joint kinematics and kinetics, and there is a role for gait training to decrease hip joint loading in Perthes disease. Thank you.